The Bobby O Show.
Welcome to the Bobby O Show. My name is Bob Opotzner, and I've got a show today that is very important to all of us. In the news, there's been a lot of talk about health care, the cost of health care, and also insurance. And I think we have an expert today. I know we have an expert today who is very knowledgeable in that field, although I will note that as I watch my roll into the show, you'll see there's 3 or 4 pictures of ladies who are cancer survivors. And my law firm has been a big supporter of Relay for Life and those types of things. And you'll see people who are listed who luckily, although they've had cancer, they are survivors. So to my guest, Ted Okon, who I'll introduce in a second, it's just nice for me to remember that those are people who you serve in the job that you do. So let me say hello to my good friend for years and years and years, Ted Okon. Hi, Ted.
Hey, Bob. How are you?
I'm doing fine. Thank you very much, Ted. Let me read something that you sent me that I want to introduce you to the audience, and I'm going to have some questions about the things I'm reading, but I think it tells us a lot about who you are and what you can talk about today that's going to help the people in America understand a lot of the issues that I've mentioned already today that are important to our society. It says, Ted Okon is a nationally recognized expert on the policy and politics of cancer care. He has quoted extensively in the press, including guest appearances on TV and radio news shows. I'm sure being on the Bobby O Show is one of the highlights of your TV appearances, Ted. It doesn't say that in the lecture. Ted has testified before Congress on cancer issues and is frequently on Capitol Hill discussing the nation's cancer care delivery system. Ted's target areas of expertise, including the cost of cancer treatment, healthcare reform, Medicare reimbursement, pharmacy benefit managers, PPMs they're called, and I'll come back to ask Ted to define that in a moment, drug shortages, and the changing landscape of cancer care delivery in the United States. Ted has dedicated his career to healthcare business and policy. He has worked for several pharmaceutical companies, including Merck and Warner Lambert, now part of Pfizer, and IMS Health. He co-founded and took public the Healthcare Information Business Medical Marketing Group. He also founded 2 oncology companies, an oncology clinical research network, and an information network, and has traveled extensively to China, India, Singapore, UK, and the Middle East, analyzing and discussing cancer care delivery. And we'll later on talk about maybe some of the differences between the cancer care delivery in those countries and what we have in the United States. An executive director of the Community Oncology Alliance, COA, Ted oversees the strategic direction of this nonprofit organization dedicated to patients and providers in the community cancer care setting under the direction of a dedicated board of oncologists and practice administrators. Ted also travels the country speaking to state oncology societies, professional organizations, and companies about the challenges facing the nation's cancer care delivery system. He also travels, I'm sure, to watch Notre Dame football games, which he is a big fan of. He has authored numerous articles and studies related to cancer care policy and politics, reimbursement, and clinical issues. Ted holds a BS degree from Fairfield University, an MBA from the Carnegie Mellon University Tepper School of Business. His wife, Susan, practiced as a certified oncology nurse. Ted, I don't know when you sleep, but I think you left out a couple of important parts of your resume, and I'm just going to add those. One is that he's a recent grandpa to a wonderful daughter named Katie, who I've known since she was a little girl. In fact, there's pictures of Katie and your family, Ted, at a circus at the Shelton High School parking lot.
That's right.
His mom, Gloria Okon, was a famous TV star, I'd say, back on WPIX, I think it was, right, Ted? Mm-hmm. Many years ago. And his brother, Tom Okon, is the actor, the little boy, in the best advertisement of all time, in my opinion, and many opinions, the Mean Joe Green commercial. So other than that, Ted, there's nothing more to say about you. So I guess the show must be over. I'll talk to you later, Ted.
Well, Bob, the one thing I have to say, though, is, and I was reminded that watching the intro, is that, as you know, 3 years ago, we moved to North Carolina, and I'm in a lot of different color blue than Duke right here where I am in Pinehurst. There's a lot of that lighter blue color, do I say, the school. So just reminded me as you, Mr. Duke, in your intro.
Well, actually, you are correct. And I should say this for the record. I've invited Ted to go to see a Duke basketball game in January, and maybe he'll go to the game, and maybe he'll even root for Duke.
It's an experience going to see Duke playing Cameron. That is really a treat, which you've invited me to before, and we have gone.
1998, we saw the Fairfield University basketball team play. The Stags played under Coach Tim O'Toole, and we went to the game together. And Fairfield was ahead in the first couple minutes, and then they turned the clock on. In any event, the show is not about Fairfield or Yale or Duke basketball. It's about a very important topic. And Ted, I'd like you to explain a couple of things to me. First of all, how did you get into this field of what I described, what you're doing?
Well, Bob, about 25 years ago, basically, I was involved with a oncology practice, a large clinic actually in Memphis, Tennessee, and I was running two of the businesses associated with that. And we learned that they were going to change Medicare reimbursement. This is when Medicare Part D, as in dog, that is the prescription drug benefit of Medicare, was created. And we understood they were going to change how they reimburse for cancer care and other therapies. And long story, a lot longer than I can tell in an hour, but a number of us, a number of oncologists and administrators run practices, went up to Washington, D.C., and we ended up creating the Community Oncology Alliance, a nonprofit, which I volunteered as a co-executive director when it started, because I was traveling the globe, as you mentioned in my readout in the bio. I had to sort of drop out. And again, it's a very long story, but about 14 years ago, a lot of the docs came to me and said, okay, what should we be doing differently? Would you help us out here? Because any organization sort of has its own growing pains. And I said, sure. And because I was not involved, we sold off a couple businesses. They asked, would you be the executive director? Because I told them, you need a full-time paid executive director, not these volunteers, as I started out by doing. And I said, sure, I'll do that for 2 years. I'll give you 2 years, and that'll be it. We'll put it on a good course. And that was about 14 years ago, maybe even going on 15 years. And I'm still here. And one of the reasons is that cancer is a part of everybody's lives. As you mentioned, my wife, Susan, worked at Yale for 10 years in their Smilo. They're basically their outpatient cancer unit. It's touched us personally. I have more stories and more people that come that can't get their treatments. They're too expensive. Someone's blocking it, an insurance company. So the long and the short of it is, it's just something that I've kept on doing and will do for at least a couple more years going forward. We have a great team, but there's a lot that needs to be done because there's a lot of problems with healthcare, which we'll touch on.
And in the area of transparency, I've known Ted since he lived in Monroe, Connecticut in the mid-1980s. I should mention for transparency that I've represented Ted in the past and some of the entities he mentioned already. But I've had also the pleasure of watching him grow in terms of his involvement in the activities that he talked about. And one thing I think is very interesting, Ted, is when you mention the business, or I mentioned the business of Medical Marketing Group, that entity essentially was getting data on medical treatments. And I think that's very, very important because you had a vision at that point in time about the importance of coordinating data and keeping track of data. And it's a critical element. Can you talk about that part of your background that leads into what you're doing now?
Yeah, well, I mean, I think that there is generally, especially back then, there was a complete lack of transparency in terms of data, and certainly data and information that's useful for a patient, whether it be a cancer patient or someone else. So we basically pioneered a lot of the use of data, and now you see data all over the place. In fact, all of the big hospital systems, the insurers are required by law to report their cost data and have that in an accessible format, which they fought tooth and nail, but have that in an accessible format that somebody can compare. You know, you go to buy a car, you go to buy a washing machine, whatever it is, the bottom line is, you know what the cost is. The problem is that when it comes to healthcare, you don't know what the cost is. So I feel good that we did a lot of work in sort of pioneering the use of data and information in healthcare. But boy, we still have a lot of we have to do so much more now than we're even doing.
I think in lay terms, I think the way you described it to me, and this is 40 years ago in the mid 80s. How did we get so old, Ted?
I don't know, Bob. I can't believe it.
The analogy was essentially if there were 3 cardiologists in Fairfield County and there's a particular drug that could be used A, B, or C, it'd be important for the pharmaceutical companies, for example, to know what drug does in what area uses drug A, who uses drug B, who uses drug C, and that kind of data is what we're talking about. Is that, Ted, a sort of a good lay summary of what that data was?
Yeah, Bob, and it also then sort of snowballs into the idea of having that data and information being facing to the patient as well too, and that's what we're seeing now, and that's what's so important. It's important that you literally, not just pharmaceutical companies, understand what that oncologist or that cardiologist is prescribing, and then they use it for marketing reasons. It's important now that patients have more transparency into the cost of their healthcare.
Ted, I'm going to go, before I get to a little more details, you're working now as the executive director of the Community Oncology Alliance, COA. Please tell us, what is a Community Oncology Alliance? What is a community oncology, first of all, and then what does your entity do?
Yeah, so in very simple terms, if you look at cancer care delivery in this system, in this country, it's either delivered in a hospital, which it may be on an outpatient basis. So I'm not talking about in the hospital per se as an inpatient. And it's the hospital which is directed by and run by administrators, or it's in an independent community oncology practice, which is run by physicians. Now, a lot of people think, oh, it's a physician-run practice. It's 1 or 2 docs in a practice. Something like Texas Oncology, I've lost track of whether it's 600, 700 providers. They even dwarf MD Anderson, the big hospital system that delivers cancer care in Texas. So, excuse me, these are not just small little practices, but they're very large practices. But the difference is they are physician run. So our organization, COA, is a national organization that we represent literally those practices, and most importantly, their patients that are treated. The hallmarks of independent cancer care, as opposed to, and I'm not going to damn the hospital side, but we'll get into it, is the highest quality cancer care, the most affordable cancer care, and that's literally in your own community. You don't want to have to travel 3, 4, 5 hours to basically get cancer care, especially when you're on, for example, chemotherapy, where you've got to come back every month to basically sit there for 4, 5, 6 hours to get your chemotherapy. So all around this country, there are networks of independent community oncology, physician-run practices that administer literally infusible chemotherapy, as well as what we have more and more now is essentially chemotherapy in a pill. We call those oral oncolytics, but it's essentially a pill that delivers that chemotherapy. And there are other treatments too. There's radiation, there's surgery. I mean, there's all things that combine, that are under the umbrella of cancer care. But that's who we represent. And we have a board of oncologists, of practice administrators, meaning the people who run these practices, and even nurses and pharmacists that represent the board of COA and is our governing board. And that's who I report to.
And when you say independent, the word independent means independent from whom?
Independent meaning not owned by the hospital, not owned and directed by the hospital. And again, I'm not damning hospitals, but as we'll get into, there's been a huge consolidation of hospitals into these mega health systems. And that has ramped up the cost of not only cancer care, but other medical care. And so this is physician directed. This is physician run, physician owned, physician directed, as opposed to in the hospital setting, where it's an administrator and a team of administrators that are running the hospital system.
And as a lay person and as an attorney as well, I have many clients in my cases who are doctors, and I see the pressures they have nowadays. And when I was a little boy, I had a Dr. Zanton when I was like 5 or 6 years old. He'd come to my house to take care of me. And I was a sick kid when I was a little boy until I had my tonsils out. And nowadays, you can tell as a patient the way that doctors who are part of the big groups, and I won't mention names of the big groups, you wonder as you sit there waiting in the office for an hour and 15 minutes late for an appointment, who's running my medical care. So I am being a little bit more negative towards the big organizations than you are. But that, as a lay person, as a consumer, I think is a trend that's not going backwards. And I think the percentage of doctors who are free of hospitals is, I think you told me, what's 15% or more, and it's going to grow. Is that about where we are now, Ted?
It is well in general that well over 50% of basically physicians are employees and part of a hospital. And not that that's all bad, but I will tell you, and again, we'll get into it, is these hospital systems, the bigger they get, the more expensive the care is for patients and the employers who may provide their insurance.
I'll give you an example that you might want to comment upon. Many years ago, my daughter was in a car collision and she's fine. But at the time of the collision, she was told by the doctor she needed to take a certain pill every day for a month. And the month happened to be February. So we got the prescription. And how many days are there in February, Ted? Except leap year 29 is 28, right? She had 22 or 23 pills. So I called up the pharmacist who I knew and I said, excuse me, how many days are there in February? And explained that the insurance company only authorized 22 pills. Well, Bobby O from the courtroom, Ted, right? And I didn't take that very calmly to understand that they ended up sending the pills. But that's the kind of concern that I think many Americans have. And I think you do in what you practice, I'm sure. And that is that we need to get back to having the patient being critical, more important than the insurance companies and the doctors and the hospitals. Do you agree with that or disagree with what I just said?
No, I totally agree. And if you look at healthcare, it should be a decision of whether it's cancer treatment, regardless of what it is, that should be a decision between the physician and the patient. The patient should have all the facts. The patient should understand what's happening, and the patient is making that decision and in concert with the physician. It shouldn't be a hospital administrator or an insurance company administrator literally making that decision. And the problem is, in this country, we have too many decisions. They're being made by the insurance company and or the hospital administrator, if you will, and really not the individual physician in concert, or the patient in concert with their physician. And, you know, Bob, I mean, you said it. I had a Dr. Vicino who used to come to me. I would get all these strep throats when I was young. He would come out. That was the pediatrician who would come out. You don't see those kind of things anymore. Our healthcare system has drastically changed, and it's not going in the right direction.
I have an eye doctor appointment now tomorrow. That was going to be January of this year. And the eye doctors group, it's a routine examination, called me very nice and said, by the way, if you're still with United Healthcare, that was the insurance company involved, you now have to get your primary doctor to recommend the specialist to do the eye examination, or else the insurance company won't pay for it. And I said, what? What would the primary care doctor know about this? And I, of course, I called up, made my appointment for December, so it didn't go through January. But I mean, is this the kind of thing that you get involved with in your independent, your Community Oncology Alliance work to try to help patients out of that conundrum, or is that sort of not within the kind of thing that you do in your lobbying?
No, you know, obviously we are looking at the big issues. I have a lobbying team. I'm registered as a lobbyist myself because I spent so much time on Capitol Hill. We spend a lot of time in different states like Connecticut and other states because they are passing laws on this. But I have to tell you, Bob, personally, I can give you an example after example. I owe a call to a woman who I helped, who I personally helped, who's a cancer patient, who said, "Hey, can you help somebody else that I have that has a problem?" Because I routinely get people that have come to me, even on Facebook, that have said, "I can't get my medications, they're blocked." And, you know, here's part of the problem. If you look at something like cancer care, and again, it's true of other areas of medicine, it's just that cancer treatment is so expensive that what happens is the doctor will tell the physician, the oncologist will tell the patient rather, that, "Hey, I think we should do X, Y, and Z," whether that is, you know, traditional infusible chemotherapy, sitting there for 4 hours in the practice and getting it, or, as I said, chemotherapy in a pill, it may be radiation or not. But what happens is more and more, the physician has to get what's called a prior authorization. Translation, that means the approval of the patient's insurance company to proceed with the treatment. Now, what's the problem with that? The problem with that is that very often you're not talking to another oncologist on the phone. You're talking to a retired primary care physician, a pediatrician, a nurse, and, you know, they are opening a cookbook, and that cookbook is literally per the insurance company. And, you know, more and more cancer treatment is individualized because we know more about the patient's background, their genes, and there's more testing that's done, and they'll deny treatment. So you have oncologists spending more time literally fighting the system to get through and basically, you know, get through this prior authorization process so they can get to the patient. It's very frustrating. And we see more delays in treatment. We see more denials in treatment. That is just really aggravating, because you have to understand something. When it comes to the insurance company, they are not about optimizing patient care. They are optimizing shareholder value, which means money. So basically, profits literally are what they're focused on, as opposed to actual patients. And they'll put up more roadblocks to patients getting their care. And that's very frustrating. So on individual cases, I mean, I can't help the world, but, you know, it's a rare exception when I get a call that I say, "Look, I just can't help you on this," or I have to get someone else to help you. I try to get involved. And I guess that's why I'm still here and I'm no saint, but that's why I'm here after 14 or 15 years.
Yeah, it's interesting. A couple of things. as you're telling that story, I'm thinking when my daughter needed her quote daddy unquote to make the phone call for her, I was healthy and am healthy at the time, knock on wood. But I was just thinking about, what if you're that person who's making the phone call, him or herself, who's got the cancer treatments that are facing him, can't get the medication, whatever. It can imagine the emotional and intellectual upset. And I also was thinking about the movie, I think it was called The Rainmaker, right? Is that the movie with Matt Damon, which was the ultimate extreme about denials? And they had a book about 2 feet thick that explained how the person answering the phone that you described was told to deny. And I'm not saying this is what happens all the time, but this is what you're trying to help people with. So let's jump on to what, if I've asked you what you do, what specifically can you do you try to do to try to help in healthcare, especially in the oncology field in America today? What are you doing specifically to try to help?
Right. So there are a number of things that we do. One big thing that COA is known for is if you go to Washington, D.C., and you basically ask members of Congress and you say that are especially in healthcare related committees like the Energy and Commerce Committee on the House, the Ways and Means Committee on the House, the Senate Finance Committee, or the Senate HELP Committee, Health, Education, Labor, and Pensions, and you say COA, they will know. We've just been around. We've been a presence. When you say cancer, it's COA. So we spend a lot of time lobbying in Washington, D.C. Why? Because Medicare, which basically is primarily for those 65 and over, and actually some disabled individuals who qualify for Medicare, cancer tends to be a disease that is more prevalent as you get older. So the primary big payer is Medicare, and then the commercial insurers, the United Healthcares, the Cignas of the world, and et cetera, they basically very often follow the Medicare lead. So Medicare is very important. So we spend a lot of time on policy because a lot of the policy that has been enacted in Medicare has actually fueled the consolidation that we see of not only hospitals buying up hospitals, but hospitals buying up physician practices. And so what we try to do is not just say that's bad policy, but we literally suggest and say, this is what the policy should be. So on a number of different fronts, we are up there lobbying. In addition to that, the actual states have become more active in terms of certain policies, especially with, and I know you're going to come back and ask me about pharmacy benefit managers, or as they're known, PBMs. And there are more states that see the sort of the evil of these big PBMs and what they're doing in terms of delaying and denying care to literally constituents, patients within the state, and creating what has become known as pharmacy deserts. So states are more active. And actually the fact that states are more active and have done more than Congress has fed Congress to do more. The problem now is that, full disclosure, I'm a registered independent for a lot of reasons, but Congress is fundamentally broken. I mean, it is more of you say day, I say night. You say white, I say black. It is become more about the politics, unfortunately, as opposed to sitting down and saying, okay, here's my perspective. What is your perspective? And let's work that out. A classic case right now is that anybody who has Obamacare plans, ACA plans, are facing a huge increase in premiums. And instead of working out a solution to that, of which there are a number of solutions, is, the Democrats are saying, we want this fixed forever. That costs a ton of money. And the Republicans saying, we don't even want this fixed on a short-term basis. And it's become more about the politics as opposed to, real people who are going to have to make decisions. Do I keep my insurance or do I put food on the table? So this is a big deal. But what we do is we advocate. We also have a patient advocacy network that basically is very involved in terms of educating patients. It's really important that patients be also some of their own advocates. And we're very involved in getting practices to come to Washington, D.C. to what we call Hill Day or fly-ins, so that literally the constituents from like Connecticut are talking to their two senators and whatever representatives that they have in the state.
Ted, I want to interrupt for 1 second because I want to go back and have you discuss a little further what you guys do. But you said a little bit ago that you advocate certain policies that your organization, I'll call it COA, thinks is appropriate. How does your organization decide what policies they or it is going to advocate for? How does that determination made?
Yeah. So basically, a couple weeks ago in Washington, D.C., we held a legislative day where we brought in a number of different representatives from practices, our internal team, and based on a survey that we did of asking, what are the most important things to you? What is getting in your way of providing, high quality, affordable care to your patients? So, for example, one of the things that's at the top of the list is prior authorizations. This is a big, big problem, is the fact that prior authorizations are not decreasing, they're increasing. And that means that more and more that oncologists will have to get on the line with that retired pediatrician, whoever, trying to explain why this is optimal cancer care for this patient. And so as a result of that, we take the input of that survey, we bring people into Washington, D.C., and we literally sit around for a day and prioritize what we should be doing. So that sends us into, in this case, 2026, with a game plan of what are some of the most important issues that we should be lobbying on and how we should do that. And we have our lobbying team as well as our legal team. And that sets the stage. And then we basically course correct as events happen. For example, Congress has to go back and has to fund the government past the end of January. And if they don't, we're going to hit another shutdown. So all they've done is sort of punt this down the road. And with that, there may well be this time around certain healthcare provisions that will accompany basically, that keeping the government open. So we may find that we may be able to get a couple things in there, and we would course correct as we go along. So
excuse me, and to say this, and I could be more political than you are because when you and I are offline, we'll talk about anything, including how Duke gave you a quarterback last year for Notre Dame, but that's another story, Riley Leonard. The thing that concerns me in many respects is that I don't think people realize that the number I keep hearing is 20 to 22 million people over a certain number of years will be off health insurance. And the problem we have sometimes in our society is that, well, I'm making money. I have my insurance. It's not me, so I won't worry about it. But it's my understanding that because of what's going on in Washington, D.C. on this political front you've talked about, people who are not on the Obamacare subsidies are also going to get impacted by significant increases in health insurance. My question is that information or understanding accurate from your perspective? And if so, what can be done to broaden the support in our elected officials? And you are correct. Congress is broken. Congress is broken. And the reason it's broken, and we'll have another time of discussion, but when you only have 20 or 30 congressional seats that are truly open and they're not pretty much Democrat or Republican, if there's no accountability by the electorate, things don't get fixed. But to my first question I just asked you, what do we do with this cost situation? Am I accurate that it's affecting not just those in the subsidies, but also others who are not in the subsidies?
Yeah, and part of the problem, Bob, is that people have to understand that the large insurance companies have consolidated. Okay. So if you look at something like United Healthcare, the biggest insurance company in this country, United Healthcare not only owns basically mail order pharmacies and one of the largest PBMs, which we'll come back to, but they own 10% of the physicians in this country. Literally 10% of the physicians, close to 100,000 physicians in this country, are under United Healthcare. So what happens is, as we've had merger after merger and consolidation, these big insurance companies literally have tremendous amount of leverage, and they're going to make money one way or another. So if they get hit over here in terms of making money, they're going to increase premiums over here. And we've seen this rise in premiums because they can do it. They can do it. That's what it is. So it's amount of leverage. And the bigger you get, the more leverage you have. So yeah, it's a problem in that, you have two things. A lot of times people, and it's one thing when somebody's very healthy and says, well, I'm not going to get sick, so I'll take a plan that has a very low premium. The problem with those low premium plans are, if you get something like cancer, they have huge deductibles and there's huge coinsurance, so that when you get hit with a $10, $20, $30, $40, $50,000 cancer bill, you're in trouble. On the other hand, if you're going to say, hey, I'm older, I need more protection, well, your premium's going to be a lot higher. It's all tied together. And so that's part of the problem. So we spend a lot of time talking about the policy and the implications. And I don't like to be someone who says, that's not working, don't do that, don't do that. I'm someone who basically says, hey, I want to hear the solution. So last year, we put together what's called the COA Prescription on Healthcare Reform. It's on the.
Second slowly. What is it called again?
It's called the COA Prescription for Healthcare Reform.
Thank you.
It's on our website. You go to our website, communityoncology.org or coacancer.org. It'll get you to the same place. And basically, you will see this prescription for healthcare reform that tells the Congress, this is what you have to do. And we've said there's one fundamental problem of why healthcare is increasing in cost, and that is consolidation. And you see that consolidation, as I've said before, among the insurance companies. You see it among these big mega health systems. You certainly see what's happening in Connecticut, Bob, with Yale and Hartford Hospital. And I'm not damning anybody. I'm just saying the bigger they get, the quality doesn't go up, the cost goes up.
As I'm hearing you, I'm saying to myself, you mentioned the word leverage, which might be one of the most important words you've mentioned in this show so far. I'm thinking, what leverage does one have? Because if you only have three big insurance companies, it's called an oligopoly from college and law school, et cetera. I'm thinking back when I was on the Board of Education. As you know, I spent 15 years on boards of ed, 9 years in Shelton, where I used to live as a kid, and 6 years where I live in Richfield. And I was always head of negotiating committee. I wonder why, right? And about every 3 years, we would go out to bid for changing the insurance carrier. We had to get the union approval, et cetera. And the last time we did it was like in 2003 was the last time I was on the Board of Ed. And we saved like $1 million by changing from company A to company B of those three companies that were in existence. And they would always give us a loss leader for a 3-year contract. And then in 3 years, they'd be the highway, and we'd go back and forth. But we had negotiated power because as a school district, we had something they wanted, but it's just lay people. It's a problem. So the question then becomes, from when we were kids, if you were not a part of the solution, you're part of the problem. Remember that when we were in the 70s and whatever, what can be done? And if you're going to say to me, we need the House of Representatives and Congress to help us out, I'm not sure if that's going to get us too far, but is there anything else we can do to try to stop the continuing monopolies in our country that are going to impact healthcare the way it's being impacted?
Yeah, it's a real problem because, frankly, the FTC, the Federal Trade Commission, under both Democrats and Republicans, has really done a failing job in terms of letting these mergers take place that have created consolidation, which basically have given huge inordinate power to on one side these mega health systems, on the other side these insurance companies, and as a result of that, it's a real tough one. So what the process that we take, you can't go into Congress and say, hey, break these all up, but you can do a lot of things even at the state level, and I'll give you an example of that, is in terms of legislation that sort of neuters, if you will, certain things that they do. So let me give you an example. Is that, again, you said a lot of your listeners are not going to have any clue what a pharmacy benefit manager is. These are entities that work behind the scenes that basically started out by literally processing the claim between the pharmacy and the insurance company. Somebody has to basically process that and have the money flow. Well, these pharmacy benefit managers have grown so big, and they're all owned by insurance companies, that basically the top three that are associated with United, with Aetna, and Cigna control 80% of the prescription drug market. So think about a meter, whether you're thinking about a meter of water that sort of flows through these pipes. And as a result, they create a lot of damage. So in Arkansas, I'll give you an example, is that Arkansas passed a law, and it took a lot of work to pass a law to say, wait a minute, a company that basically owns, regular pharmacies, like CVS, right? You see CVS all over the place, cannot own also a PBM. You need to decide whether you're going to be a PBM or whether you're going to be a pharmacy. That law passed. That meant that basically these companies that own, whether they're brick and mortar pharmacies like you see CVS, or whether they're mail order pharmacies or special pharmacies, would have to say, I'm either going to be in the pharmacy business, right, which is actual drug moving, or I'm going to be in the pipeline business of being a PBM. The PBMs basically got an injunction and have a preliminary injunction, which is being fought by the AG, to not let that go through by literally making arguments that really don't make a lot of sense. So, we actually filed an amicus brief, literally with the state, basically saying why this needs to go through. So even at the federal level, there's a push on terms of extracting some of these PBMs from pharmacies. But the problem is that you have, again, United Healthcare that is the biggest insurance company, that owns 10% of the doctors, that has one of the largest PBMs. And I can go right down the list of the things that they have. That makes it very difficult because, again, it gets us back to that word leverage. They have tremendous leverage and control. And that's why you see more and more that the big hospital systems that consolidate and the insurance companies that consolidate fight. And a lot of times patients get caught in the middle because.
And Ted, this is where, and we're not getting into politics today in this show, but you can't avoid politics.
Yeah.
Because you have elected officials who are political. But if you have what you just talked about, these big multi-billion, trillion-dollar companies out there, if you have an elected official in Washington, D.C., or in the House of Representatives, or the president, executive, or legislative branches, and there's a huge contribution being made to the elected officials, query whether or not they're going to say, well, you know what, Attorney General, let's not fight at this issue. Let's not rock the boat. And I think that's part of the problem, which goes back to the Supreme Court decision that took away a lot of the limitations on campaign funding. And to me, if I were king, there's two things I would do. One is I put limitations on the pardon power for the president. And number two, I would make sure that there is limited campaign financing so that if I write my $1,000 check or someone writes a $100 check, whatever, there's a limit. And then I would think, in my opinion, you will find less of the pressures that can be asserted by the big mega companies. You can comment or no comment if you'd like.
Yeah, no. I mean, I think that's legitimate, but I think unfortunately, Bob, that's not going away. And I'll tell you the other thing, regardless, is that the old adage is that the two biggest employers in a district, in a United States Representatives district, are car dealers and hospitals. And so it's not just the money, which is certainly part of the issue. It's the voting constituents. So somebody who has to run every 2 years, as every 435 representatives need to do, they've got to pay attention. And the more people that are under the umbrella of an entity, the more that they believe that that's where the control is. So it's tough, and it is tough, and we know that we have a healthcare crisis. It's costing Americans more for their healthcare. And look, yes, our drugs part of the problem, and our pharmaceuticals, and it starts with pharmaceutical companies, but it's not just literally the pharmaceutical companies. It's literally the discounts and the rebates that they have to give away to these leveraged entities. And then it's also what the person's insurance design is. So, a lot of people talk about, the price of prescription drugs, and my friend, Dr. Mark Fendrick at the University of Michigan, who's one of the top, experts in this area, always says there's the price of the drug, and then there's the cost to the consumer, the patient. And the patient doesn't know, in most cases, the price of the drug. They know the cost of the drug to them. And there is a radical difference in many cases between the underlying price of the drug and the cost of the drug. You talk
about the insurance costs and people going for the least expensive premium, for example, not because they want to, because they have to. As part of my litigation practice, I've always done personal injury cases, car accident cases, and there are certain kinds of car insurance policies that people can get called uninsured motorist coverage in Connecticut, which means essentially if you hit me and don't have a lot of insurance, my company will pay whatever. And there's something called conversion, which says you could be an add-on or not to the policy. I make the point because invariably I'll see some of their policy and I'll say, wait a minute, you don't have, the guy who hit you has $20,000 in liability coverage and your damage should be worth $100,000 and you didn't get the right plan because you could have, for $100 a year, gotten the better coverage. And the response is, well, it was cheaper the way I went. And so I think no one's free of blame. We as consumers have to be alert as to what we do in our insurance policies, et cetera. I want to transition to something more, and that is you talked about policies that your company, your entity is doing. I want to mention that one of my major concerns, you can comment on this or not, but we have our health system of our country being run by, I would say, a lunatic. That's my word, not yours, who is not a doctor, who has this perspective that vaccines are terrible. And I remember hearing yesterday, the day before, that 10 kids died from vaccines. And I empathize for the family who lost their 10 kids from taking the vaccine. But there might have been 2 million kids who were saved by having the vaccine. And I'd like you to know what, if anything, your entity does in terms of involvement in pro or con or having vaccines determined by science, not by a politician or, in my word, not yours, a lunatic.
Yeah, well, we don't really, vaccine isn't an issue because there's only one in cancer, Bob. So we don't get involved in that. I can just tell you personally that I had the pneumonia vaccine, I got the COVID booster, and basically the flu vaccine. So I tell you where I'm coming from, but we, right now, we don't have vaccines in, in cancer, except for in sort of one case. And so, unfortunately, we're really not involved in that. Although obviously we spend a lot of time with HHS and also with CMS, the Centers for Medicare and Medicaid services policy underneath HHS. We spent a lot of time there, as I said, not just with the Congress on that policy, but with the administration.
And Ted, I cut you off before, so we'll get back into the topic. Are there any more things that your entity is doing in the field of healthcare and oncology work, et cetera, that I cut you off from saying? Is there any more you want to tell us that you're doing?
No, I mean, Bob, I could sit here for literally hours, and tell you everything that we are doing in terms of every aspect of, there are more hurdles, there are more obstacles that get in between the patient and their physician, and the patient and their optimal care that is the most affordable care. Again, unfortunately, we have too many examples of where patients are delayed treatment or denied treatment, for crazy reasons. So we spend a lot of time, and we have a lot of issues. And it goes back to you where you basically said, hey, how do you figure out where you're going to do, what do you prioritize? That is that process that I explained to you that involves, our legislative, it means querying practices, surveying them to see what the issues that they face, turning around, and then basically having, a whole group, multidisciplinary group, decide we're going to prioritize. And then during the year, basically, as events happen, as legislation happens, is make course corrections along the way. But unfortunately, there are more issues that are getting in the way of cancer patients and other patients. I mean, I'm representing cancer, but basically of getting their optimal treatment. There are more issues, and it's because of consolidation. It's the little patient who's caught in between the consolidated entities that are sort of duking it out.
Ted, sometimes I forget at the end of the show to ask my guest how people who are watching the show can find out more about Community Oncology Alliance. So before I forget to do that, why don't you just tell us what your website is and how people can find out more about the great work you guys are doing?
Yeah, I mean, we have a ton of information on our website. You go to communityoncology.org, O-R-G. You can also coacancer.org, but communityoncology.org. We have more studies, resources every day during the week. We put out sort of the latest news that relates to cancer policy, things that are happening in DC. So it's a pretty robust site of information, of published studies and other information.
Ted, you talked before about the community aspect of cancer treatment. And a bad analogy is that sometimes people who are in hospice say, you know what, I want to go back to my bed in my house and not die in the hospital. And I'm not saying people are going to die from cancer, but that's where things come up. I tie that into the concern that I've been hearing and reading about for the last several months, that because of the subsidies issue being removed from the Obamacare, that hospitals and facilities may be shutting down, which may have a very bad negative impact on people in rural communities. If that is a reality, that is or could be happening, how would closing of hospitals and facilities like that in rural areas negatively impact this community oncology services that you're advocating?
Well, I mean, it's already happening. Rural hospitals, small hospitals, even in urban areas, Bob, but rural hospitals are under a tremendous amount of pressure. And basically, without getting really caught in the weeds, it's the big, well-financed mega systems that are actually receive benefits that bleed the small rural hospitals basically into non-existence. So, I mentioned before that these PBMs are causing pharmacy deserts. We're seeing independent pharmacies basically dry up and creating deserts across the country. You're now seeing in rural areas medical deserts. And what's scary about both of those together is in many areas, in rural areas, where you don't have a lot of physicians, it's the pharmacist and it's the independent pharmacist who's actually providing care and advice in a limited way that a pharmacist can do. And so when you have both pharmacy deserts and then you have, these medical deserts, especially with these small rural hospitals, it's a problem. I mean, there was a study done a couple of years ago showing how rural hospitals that provide cancer care are drying up and closing. And it's a big problem, but it's, again, without getting into the weeds, because it would take me an hour to explain it. But the bottom line is, with the consolidation of these big, wealthy, well-endowed medical systems, basically they are having an adverse impact on these rural systems. And it's a very scary thing.
Ted, one thing, we only have 2 minutes left in the show.
Yeah.
Time flies fast when you and I are talking, even about the Giants. We won't get the Giants today.
No, we're not going there.
But it ties into mental health issues. And we are lucky in the Danbury, Connecticut area. Did I lose you?
No.
Okay. We are lucky in the Danbury, Connecticut area that we have an entity called Ann's Place. I'm not sure if you ever heard of Ann's Place. You have heard of it? Mm-hmm. Shannon Cobb, who's the director, I actually called her before our show today saying, you got to watch today's show because it's important. What Ann's Place does, for those who don't know, essentially it deals with the crucible. It deals with the family. So if, let's say, Papa has cancer, it deals with the children, the wife, the family members, to try to help them deal with this crisis. And Shannon's on my show many, many times. And in fact, one of the pictures you have of my coming on the show, you'll see Ann's Place is one of the things we went to for a rally. My question is, does your entity get involved at all in these sort of mental health tangential activities? Oh, here are the pictures we have, by the way, before I leave, Ted. Thank you, Candy Ann. These are pictures of Ted advocating for his activities. That's before Congress, right, Ted?
Yeah, that's before the Ways and Means Committee.
Sure. So anyway, Ted, in the last few seconds you have, do you get it all involved in helping those facilities that are advocating for people as a crucible to help the families?
Well, yeah, mental health issue are really, really important. And we have a lot of practices that on a regional basis deal with those kind of entities in terms of mental health, because you see the pressures that are put on families when, especially a lot of times when it's the primary earner basically has cancer and what it does to the rest of the family. So the short answer is yes. We don't necessarily do that on a national level, because really where that plays out is on a regional, local level.
Ted, I want to thank you so very much for coming on the show remotely. I want to remind people that we are the United States of America, which means that we don't want healthcare to be better in Connecticut than it is in North Dakota, et cetera, et cetera. And I think the work that Ted does, he's a man of integrity, a brilliant guy who's very lucky to have his wife, Susan. And the work you do is very important. I want to thank you very much for what you do and take the time to come on my show. Thank you so much.
Thanks, Bob. It's an honor I always enjoy talking with you, and it's certainly an honor to be asked to be on your show. And hopefully, your listeners just get a little bit of information about, our very convoluted, messy healthcare system in this country that's not getting fixed, especially with, a current broken Congress.
Shalom, Bob Potzer, The Bobby O Show. See you next time, folks.